Hello, dear student. Today you have new topic about gastroenterology and discuss about dyspepsia and chronic gastritis. So let's start. What is dyspepsia? Dyspepsia symptoms include a constellation of upper gastrointestinal complaints such as belching, postprandial fullness, early satiety, epigastric pain, and epigastric burning. Functional dyspepsia is diagnosed when an agonic etiology for the symptoms is not identified. Dyspepsia is secondary to organic disease. Although there are several organic causes for dyspepsia, the main causes are peptic ulcer disease, gastroesophageal reflux medications, and gastric malignancy. Although gastric cancer as a cause of dyspepsia is a concern for both healthcare providers and patients, it is uncommon in North America. Peptic ulcer disease, upper abdominal pain or discomfort is the most prominent symptom in patients with peptic ulcers. Although discomfort from ulcer is usually centered in the epigastrium, it may occasionally localize to the right or left upper quadrants, while classic symptoms of duodenal ulcer occur when acid is secreted in the absence of the food butter. Peptic ulcer can be associated with food-provoked symptoms, and thus the utility of using symptoms related to food ingestion to predict the presence of an ulcer is unreliable. Peptic ulcers can be associated with postprandial belching, epigastric fullness, early satiation, fatty food intolerance, nausea, and occasional vomiting. Gastroesophageal malignancy. Gastroesophageal malignancy is an uncommon cause of chronic dyspepsia in the Western Hemisphere, but the incidence is higher in patients of Asian, Hispanic, or Afro-Caribbean extraction. The incidence of gastroesophageal malignancy increases with age. When present, abdominal pain tends to the epigastric walk and mild early in the disease, but more severe and constant as the disease progresses. In addition, other symptoms and signs typically involved with disease progression. Biliary pain. Classic biliary pain is characterized by episodic intense dull pain located in the upper quadrant epigastrium or substernal area that may radiate to the back. The pain is often associated with diaphoresis, nausea, and vomiting. The pain is constant and not colicky. It is not exacerbated by movement and is not relieved by squeezing, belching, bowel movements, or passage of flatus. The pain typically lasts at least 30 minutes, plateauing within an hour. The pain then starts to subside with the entire attack usually lasting less than 6 hours. Drug-induced dyspepsia. Non-steroid anti-inflammation drugs and cyclooxygenase 2 selective inhibitor can cause dyspepsia even in the absence of peptic ulcer disease. Other drugs that have been implicated in drug-induced dyspepsia include calcium channel blockers, metixaltin, alendronate, orlistat, potassium supplements, acarbose, dabigatran, iron, vitamin D, selective serotonin reuptake inhibitors, sildenafil, and certain antibiotics, including erythromycin, and other causes. Celiac disease and chronic pancreatitis may rarely present with dyspepsia alone. Other rare causes for dyspepsia include infiltrative diseases of the stomach, diabetic radiculopathy, metabolic disturbances, hematoma, steatohepatitis, celiac artery compression syndrome, superior mesenteric artery syndrome, abdominal wall pain, and intestinal angina. And functional dyspepsia. Functional or idiopathic or non-ulcer dyspepsia requires exclusion of other agonic causes of dyspepsia. It is defined by the presence of one or more of the following: postprandial fullness, early satiation, epigastric pain or burning, and no evidence of structural disease to explain the symptoms. The pathophysiology, diagnosis, and management of functional dyspepsia are discussed in detail separately. And you may see functional dyspepsia is defined by Roma 4 criteria and subclassified into postprandial distress syndrome and epigastric pain syndrome. And what is it? Yeah, postprandial distress syndrome is postprandial fullness or early satiety more than 3 days a week for the past 3 months and onset more than 6 months before diagnosis. And what is it? Epigastric pain syndrome is epigastric pain and or burning more than 1 day a week for the past 3 months and onset more than 6 months before diagnosis. And postprandial distress syndrome meet in 38% of patient. Epigastric pain syndrome meet in 27% of patient, and combine two syndrome, postprandial and epigastric, meet in 35% of patient. And characterize postprandial syndrome: early satiety, bloating, nausea, vomiting, retching, decreased appetite. And characteristic for epigastric pain syndrome are epigastric pain and epigastric burning. And etiology of functional dyspepsia: gastric neuromuscular dysfunction, including delayed gastric empyema, gastric fundus relaxation with blunting of postprandial accommodation, and altered gastric mechanosensitivity has been of particular interest in this area. And next, in etiology, psychological distress. Psychological distress has been associated with dyspepsia, with research showing both that distress and anxiety can precede symptoms and that symptoms can induce distress and anxiety. Thus, a bidirectional gut-brain pathway mechanism has been proposed. And next, in etiology, duodenal acid exposure, dysmotility, and inflammation. There is preliminary evidence concerning the presence of increased postprandial duodenal acid exposure in functional dyspepsia patients with prominent nausea symptoms. In addition, duodenal motility and bolus clearance impairment have been induced by instilling acid into the duodenum, raising concern that duodenal acid driven pathology may contribute to dyspepsia symptoms in a subset of patients. There is growing evidence regarding the role of duodenal inflammation and duodenal eosinophilia in functional dyspepsia. Duodenal inflammation and in particular duodenal eosinophilia has been seen in up to 40% of patients with functional dyspepsia. And alarm future for functional dyspepsia. Unintentional weight loss, new or progressive dysphagia or dinophagia, persistent vomiting, unexplained iron deficiency anemia, palpable mass of lymphadenopathy, family history of upper gastrointestinal malignancy, childhood spent in country with high risk of gastrointestinal malignancy. And diagnostic evaluation. By definition, functional dyspepsia is diagnosed into the absence of an organic etiology for the dyspepsia symptoms. As outlined previously, patients with functional dyspepsia report a range of symptoms that can vary greatly in severity, and symptoms are not a reliable way to differentiate organic from functional dyspepsia. Thus, the goal of evaluation is to rule out organic etiologies for patient symptoms. Evaluation is based on patient age, presence of alarm features, severity of symptoms, risk of malignancy, and physical examination findings. Patients under age 60 years without alarm features should undergo Helicobacter pylori testing via stool antigen testing or urea breath test, followed by treatment and eradication confirmation if testing is positive for active infection. It is important to ensure that patients undergoing testing do not take a proton pump inhibitor for 4 weeks prior to testing, and PPI, proton pump inhibitor, use can cause a false negative test result. And treatment. Helicobacter pylori eradication. Although Helicobacter pylori-associated dyspepsia is not technically considered under the umbrella of functional dyspepsia, Helicobacter pylori infection should be treated and confirmation of eradication should be performed if clinically indicated. Helicobacter pylori infection is identified in approximately 5% of dyspepsia cases. Next in treatment, acid-reducing therapy. PPI therapy is considered first-line therapy for functional dyspepsia. However, studies have shown PPI therapy to be ineffective in treating functional dyspepsia in only 14% of patients. Next, neuromodulator. If PPI therapy is ineffective or provides inadequate relief, guidelines by the American College of Gastroenterology and Canadian Association of Gastroenterology recommend a trial of neuromodulatory medication. Next, prokinetics and fundus relaxing therapies. The effectiveness of prokinetic agents to treat functional dyspepsia is unclear. The potential benefit of prokinetics was supported by a meta-analysis that demonstrated benefit with sitaprit, domperidone, and etioprid therapies. And next step, psychological therapies. 58 patients with functional dyspepsia were randomized to either medical therapy alone or with psychotherapy, with great improvement in the dyspepsia-related quality of life scores in the combination therapy group. And you may see functional dyspepsia treatment algorithm, and this algorithm depend present inpatient Helicobacter pylori or not, and different treatment for positive Helicobacter pylori testing and negative Helicobacter pylori testing. And next part of today's lecture is chronic gastritis. So, information about gastritis. The term gastritis was first used in 1728 by the German physician George Ernst Stachel to describe the inflammation of the inner lining of the stomach, now known to be secondary to mucosal injury. In the past, many considered gastritis a useful histological finding, but not a disease. This all changed with the discovery of Helicobacter pylori by Robin Warren and Barry Marshall in 1982, leading to the identification, description, and classification of a multitude of different gastritis. And you may see the Sydney system for classification of gastritis, 1990. And you may see activity, process, chronic inflammation, granular atrophy, intestinal metaplasia, and Helicobacter pylori density. It incorporates etiology, topography, and morphologic features to be documented when reading and reporting endoscopic gastric biopsies. The topography of gastritis is the core of the classification. Etiological hints can be added as a prefix and the graded variable as suffixes. And typical examples would be Helicobacter pylori pangastritis, severely active with mild pan atrophy. And next, classification and grading of gastritis, updated Sydney system. And you may see type of gastritis, non-atrophic, and etiology for non-atrophic gastritis, and gastritis synonyms for non-atrophic. Next, atrophic type divide on autoimmune and multifocal atrophic, and what is etiology for this variant of types, and synonyms for this gastritis. Next, special form and what may be chemical, radiation, lymphocytic, non-infectious, granulomatous, eosinophilic, other infections, gastritis. And etiology for this variant, gastritis, and gastritis synonyms. Yeah, for example, chemical and synonyms, reactive, or maybe reflux. Next, radiation and synonym, synonym, no, without synonym for radiation, but for lymphocytic, synonyms varially form. All celiac disease-associated gastritis. And next, special form, respectively, yeah, type of gastritis and synonyms. In clinical practice, gastritis staging is done using the operative link of gastritis assessment, OLGA, staging system for reporting gastric histology. Gastritis staging combines the atrophy score, which is determined by biopsy, and the atrophy topography, which is determined by directed biopsy mapping. And you may see this staging system with atrophy score, no atrophy, mild atrophy, moderate, and severe. And yeah, a different stage atrophy for corpus. And next, Sydney system for gradient of chronic gastritis. And you may see future and different variant. Chronic inflammation definition, increased lymphocytes and plasma cells and lamina propria, and gradient guidelines, mild, moderate, or severe increase of density. Next, activity, neutrophilic infiltrates of the lamina propria, pits of surface epithelium. Mild, less than the 1/3 of pits and surface infiltrative. Moderate, 1/3 to 2/3. Severe, more than 2/3. Next, atrophy, loss of specialized glands for the either atrium of corpus, mild, moderate, or severe loss. Helicobacter pylori, Helicobacter pylori density, mild colonization, scattered organism covering less than 1/3 of the surface, moderate colonization, intermediate numbers, severe colonization, a large cluster of the continuous layer over 2/3 of surface. And intestinal metaplasia of the epithelium. Mild, less than 1/3 of mucosa involved, moderate 1/3 to 2/3, severe more than 2/3. And Helicobacter-associated chronic gastritis pathophysiology. Helicobacter pylori is the leading cause of the chronic gastritis, peptic ulcer disease, gastric adenocarcinoma, and primary gastric lymphoma. First described by Marshall and Warren in 1983, Helicobacter pylori is a spinal gram-negative rod that has the ability to colonize and infect the stomach. The lipopolysaccharides of the outer membrane of Helicobacter pylori are a major component of its ability for colonization and persistence. The bacteria survive within the mucous layers that cover the gastric surface epithelium and the upper portions of the gastric foveal. The infection is usually acquired during childhood. The virulence factors responsible for establishing colonization include ureas, flagella, hemotaxis system, and angiosins. With increasing antibiotic resistance, these virulence factors provide alternative drug or vaccine targets for Helicobacter pylori eradication and prevention. The virulence factor responsible for immune escape help Helicobacter pylori escape from the host immune clearance and allow its persistence in the human stomach. Disease induction virulence factor genes. And you may see Helicobacter pylori on this picture. Helicobacter pylori-associated chronic gastritis progresses according to the following two main topographic patterns, which have different clinical consequences. Anteroprovenant gastritis, this is characterized by inflammation that is mostly limited to the antrum. Individuals with peptic ulcer usually demonstrate this pattern. Multifocal atrophic gastritis. This is characterized by the involvement of the corpus and gastric atrium with progressive development of gastric atrophy and partial replacement of the gastric glands by an intestinal type epithelium. Individuals who develop gastric carcinoma and gastric ulcers usually demonstrate this pattern. And information about autoimmune atrophic gastritis. Autoimmune atrophic gastritis is associated with serum antiparietal and anti-intrinsic factor antibodies. The gastric corpus undergoes progressive atrophy. Anti-intrinsic factor deficiency occurs and patient may develop pernicious anemia. The development of chronic atrophic gastritis limited to corpus fundus mucosa and marked diffuse atrophy of parietal and chief cells characterize autoimmune atrophic gastritis. In addition to hypochondriuria, autoimmune gastritis is associated with serum antiparietal and anti-intrinsic factor antibodies that cause intrinsic factor deficiency, which in turn causes decreased availability of cobalamin, eventually leading to pernicious anemia in some patients. Hypochlorhydria induced G-cell gastrin-producing hyperplasia leading to hypergastrinemia, gastrin extern atrophic effect of enterochromaffin-like cells and is hypothesized to be one of the mechanisms leading to the development of gastric carcinoid tumor. In autoimmune gastritis, antibodies are directed against at least 3 antigens, including intrinsic factor, cytoplasmic, and plasma membrane antigens. There are two types of IF antibodies, types 1 and 2. Type 1 antibody prevents the attachment of B12 to IF, and type 2 antibodies prevent attachment of the vitamin B12 intrinsic factor complex to ileal receptor. T cells lymphocytes infiltrate the gastric mucosa and contribute to the epithelial cell destruction and result in gastric atrophy. And on this picture, you may see fibrogastroduodenoscopy with atrophic autoimmune gastritis. Next variant of gastritis, granulomatous gastritis, is a rare entity. Causes of granulomatosis gastritis can be divided into infectious disease, non-infectious disease, and idiopathic, which are observed in approximately 25% of cases. Tuberculosis may affect the stomach and cause caseating granulomas. Fungi, including Cryptococcus, can also cause caseating granulomas and necrosis. A finding that is usually observed in patients who are immunosuppressed. Granulomatous gastritis has also been associated with Helicobacter pylori infection. A granuloma is an organized aggregation of combined histiocytic, lymphocytic, and plasmacytic infiltrates. When this organized collection of cells is identified in the stomach, it is referred to as granulomatous gastritis. Granulomatous gastritis is a type of chronic gastritis and can be subclassified based on the etiology into infections, non-infections, and idiopathic granulomatous gastritis. Non-infections disease are the usual cause of gastritis, gastric granulomas. This includes Crohn's disease, sarcoidosis, and isolated granulomatous gastritis. Crohn's disease demonstrates gastric involvement in approximately 33% of the cases. Granulomas have also been described in associated with gastric malignancies, including carcinoma and malignant lymphoma. Sarcoid-like granulomas may be observed in people who use cocaine and foreign materials is occasionally observed in the granuloma. Next variant is gastritis in patients who are immunosuppressed. Cytomegalovirus infection of the stomach is observed in patients with underlying immunosuppression, but it remains unclear whether cytomegalovirus gastritis promotes the development of gastric carcinoma. Histology, a patchy mild inflammatory infiltrate is observed with the lamina propria. Typical intranuclear eosinophilic inclusions and occasionally smaller intracytoplasmic inclusions are present in the gastric epithelial cells and in the endothelium of mesenchymal cell in the lamina propria. Severe necrosis may result in ulceration. Other infectious causes of chronic gastritis in immunosuppressed patients include the herpes simplex virus, which causes basophilic intranuclear inclusions in epithelial cells. Mycobacterial infections involving Mycobacterium avium intracellular are characterized by diffuse infiltration of the lamina propria by histiocytes, which rarely form granulomas. And you may see picture with gastritis, immunosuppressed gastritis. Next, lymphocytic gastritis. Lymphocytic gastritis is a type of chronic gastritis characterized by dense infiltration of the surface and foveolar epithelium by T lymphocytes and associated chronic infiltrates in the lamina propria. Because its histopathology is similar to that of celiac disease, lymphocytic gastritis has been proposed to result from intraluminal antigens. High anti-Helicobacter pylori antibody titer have been found in patients with lymphocytic gastritis and in limited studies. The inflammation disappeared after Helicobacter pylori was eradicated. Eosinophilic gastritis. Large number of eosinophils may be observed with parasitic infections such as those caused by Stoma rotundatum and Anisakis marina. Eosinophilic gastritis can be part of the spectrum of eosinophilic gastroenteritis. Although the gastric antrum is commonly affected and can cause gastric outlet obstruction, this condition can affect any segment of the gastrointestinal tract and can be segmental. Patients frequently have peripheral blood eosinophia. In some cases, especially in children, eosinophilic gastroenteritis can result from food allergy, usually to milk or soy protein. Eosinophilic gastroenteritis can also be found in some patients with connective tissue disorders, including scleroderma, polymyositis, and dermatomyositis. And you may see lymphocytic gastritis on the endoscopy, and eosinophilic gastritis. And chronic gastritis clinical presentation. Helicobacter pylori chronic gastritis, which is usually asymptomatic but may manifest as epigastric pain, nausea, vomiting, anorexia, early satiety, or weight loss. Symptoms may occur with the development of complications of chronic Helicobacter pylori gastritis, which include peptic ulcer, gastric adenocarcinoma, and mucosa-associated lymphoid tissue lymphoma. The clinical manifestations of autoimmune gastritis are primarily related to the deficiency in cobalamin, which is not adequately absorbed because of intrinsic factor deficiency resulting from severe gastric parietal cell atrophy. As disease has an insidious onset and progresses slowly. Cobalamin deficiency affects the hematological, gastrointestinal, and neurological symptoms. In multisystemic diseases, specific symptoms related to gastric involvement may be minor. Cases and granulomas secondary to tuberculosis may be found in the absence of lung disease in patients who are malnourished, immunosuppressed, or alcoholic. Patients with Crohn's disease and gastric involvement may report abdominal pain, nausea, and vomiting. Gastric involvement in Crohn's disease is almost invariably associated with intestinal disease and intestinal manifestation predominant. And common symptoms for chronic gastritis: heaviness, belching, vomiting, flatulence, bloating, and pain. And physical examination. You may see this white picture. And this video with examination a patient with chronic gastritis. Please copy this link and watch video. In uncomplicated Helicobacter pylori-associated atrophic gastritis, clinical findings are few and non-specific. Epigastric tenderness may exist. If gastric ulcer coexists, GAIAC-positive stool may result from acute blood loss. Bad breath and abdominal pain or discomfort may occur with bloating associated with bacterial overgrowth syndrome. Physical finding may result from the development of pernicious anemia and neurological complication in patients with autoimmune atrophic gastritis. With severe cobalamin deficiency, the patient is pale and has a slightly icteric skin and eyes. The pulse is rapid and the heart may be enlarged. Auscultation usually reveals a systolic flow murmur. Laboratory studies. A rapid urea test should be done of gastric biopsy tissue. Helicobacter pylori Bacterial culture of gastric biopsy tissue is usually performed in the research setting or to assess antibiotic susceptibility in patient in whom first-line eradication therapy fails. Endoscopy. Magnifying endoscopy is useful for analyzes the subepithelial microvascular architecture as well as the mucosal surface microstructure without tissue biopsy. Upper gastrointestinal endoscopy is essential for establishing the diagnosis of gastritis. Although some studies have suggested that Helicobacter pylori infection can be determined on the basis of unique endoscopy features, particularly the presence of antral nodularity, where there is specific relation between Helicobacter pylori and macroscopic feature remains controversial. The endoscopic finding is chronic Helicobacter pylori infection may include areas of intestinal metaplasia. An endoscopic multiply biopsy specimen should be obtained. Tissue sampling from the gastric antrum, incisura, and corpus is essential to establish the topography of gastritis and to identify atrophy and intestinal metaplasia, which usually is patchy. It is recommended that biopsy samples of the gastric body and those from the antrum and incisura be submitted in separate containers for pathological evaluation. Endoscopic findings in granulomatous gastritis include mucosal nodularity with cobalt staining, multiply antral ulcer, line of serpiginous ulceration, thickness antral folds, antral narrowing, hypoperistalsis, and duodenal strictures. Extensive gastric involvement may resemble linitis plastica. Endoscopic findings in lymphocytic gastritis include enlarged folds and obtrude erosions with the appearance of small heaped up volcata-like mounds packed with a central crater. The endoscopic findings of reflux and chemical gastropathy are those of gastric mucosa that is red or has red streaks with area of apparent hemorrhage. And you may see a result of endoscopy. First picture, first photo, normal endoscopy. Next, superficial gastritis. Next, atrophic gastritis. And next, intestinal metaplasia. And chronic gastritis treatment and management. Treatment of chronic gastritis can be aimed at a specific etiologic agent, such as agent is known. Some entities manifested by chronic gastritis do not have well-established treatment protocols. For example, in lymphocytic gastritis, some cases of spontaneous healing have been reported. However, because the disease has a chronic course, treatment is recommended. First of all, use diet for treatment of gastritis. And you may see gastritis diet chart with calories and time for meal. Next, you may see gastritis diet and foods for eat and foods to avoid. And what eat? High antioxidant foods, probiotic foods, garlic, licorice, fennel, anise, high fiber foods, healthy fats and proteins, and foods for avoid. Citrus, juice, tomatoes, alcohol, coffee, milk, spicy, chocolate, and pharmacotherapy. As for specific recommendation, Helicobacter pylori eradication were limited to peptic ulcer disease. Antibiotics that have proven effective against Helicobacter pylori include clarithromycin, amoxicillin, metronidazole, tetracycline, and furazolidone. One is a version of traditional bismuth metronidazole tetracycline tribal therapy. 3 different combinations using clarithromycin have been approved, including 2 dual therapy consisting of 500 milligram of clarithromycin 3 times daily, plus either omeprazole or ranitidine bismuth citrate. The cure rates reported in the package literature suggest that the 3 combinations are similarly effective. Clinical experience has known that the most effective of the regimen is bismuth metronidazole tetracycline triple therapy, followed by ranitidine bismuth citrate plus clarithromycin, and then by omeprazole plus clarithromycin. And you may see triple therapy and quadruple therapy. Triple therapy, twice daily PPI or ranitidine bismuth citrate triple therapies include the following: lansoprazole 30 mg, omeprazole 20 mg, or ranitidine bismuth citrate 400 mg orally twice daily, clarithromycin 500 mg orally twice daily, and amoxicillin 1000 mg or metronidazole 500 mg orally twice daily. And quadrotherapy for Helicobacter pylori infection typically includes the following: PPI, lansoprazole, omeprazole orally twice daily, tetracycline, bismuth subsalicylate, and metronidazole. Evaluate eradication and list 4 weeks after the beginning of treatment. Eradication may be assessed by means of non-invasive methods such as urea breath test or stool antigen test. Follow-up may be individualized depending on the finding during endoscopy. And atrophic gastritis treatment. Once atrophic gastritis is diagnosed, treatment can be directed to eliminate the causal agent, which is a possibility in cases of Helicobacter pylori associated atrophic gastritis, to correct complications of the disease, especially in patients with autoimmune atrophic gastritis who develop pernicious anemia, or to attempt to receive the atrophic process. If Helicobacter pylori is identified as the underlying cause of gastritis, subsequent eradication now is almost generally as accepted practice. Currently, the most widely used and efficient therapy to eradicate Helicobacter pylori are triple therapy and quadruple therapy. In both cases, the best results are achieved by administrative therapy for 14 days, although some studies have recommended the duration of treatment of 7 days. The accepted definition of cure is no evidence of Helicobacter pylori 4 or more weeks after ending the antimicrobial therapy. So for today is all. Thank you for your attention. If you have questions, please leave your comment under the video, and good luck, dear student. See you again.